All right, well, welcome back to the American Academy of Fixed Prosthodontics meeting. We're here. I'm John, the dental guy.
And I'm Wes, the dental guy.
And I'm excited to get to bring this guest on, Dr. Tom Taylor. I went to UConn, University of Connecticut, back a couple of years ago now. And,
just a few.
Couple of years. And during that time, I was the, you got me turned on to the AO. So I was I got the implant award at that time. So that really opened my world into the world of journals and going to those Academy of Osseointegration meetings. And it's driven a lot of kind of where I've gone from there. So I'm very thankful, first off, to you had a great effect on me long term and on some of the things we've talked about.
That's right.
And one of the things I wanted to talk to you about was we were just the other day in our journal club, we were talking about the article that you published back in the JPD in 2014, and it was about implant occlusion. And the question was, and it wasn't just implant occlusion, it was about occlusion in general. And the question was, how much of what we think we know about occlusion is expert opinion or actual data? And specifically on implant occlusion, your conclusion there was there really wasn't any data to support that overloads cause failure. So I'd like to kind of have you update us. Have you changed your opinion on that? Or is it the same?
Well, occlusion has always been a fascinating topic to me because if you look at the world's English language literature on randomized controlled clinical trials in any field, if you try to find trials that have looked at any aspect of human occlusion or function, there may be 4 of them. They usually come out of the Scandinavian literature, and they're very dry and boring, and they really don't give you much information. So the answer to your first question is occlusion is totally based on expert opinion or pseudo-expert opinion, however you want to call it. There's very, very little scientific basis for what we do on a day-to-day basis in restoring our human patients. And it's that has extrapolated exactly straight into dental implantology, because dental implants are what? Prosthetic roots of teeth. And although dental implants don't function the same as teeth and they don't fail by the same pathways as natural teeth, we extrapolate what we learned as dentists to dental implants, and we expect the outcomes to be the same or similar or even better. And I think from that regard, we are very lucky that by and large, what we have done as dentists using dental implants as tooth replacements has worked very, very well. The issue that I have with occlusion and dental implants is there are certain aspects of humanity that will not allow you to run a randomized prospective clinical trial on a human population in which you inflict damage or pain or suffering on those patients. And so anytime you wanted to look at, for example, hyperocclusion in a dental implant, there's no way you could possibly do that on a human. You can't do it. So the only way you can look at that objectively is with animal studies. And to date, I've tracked the literature in this field very, very carefully, and there are a total of 7 papers that have looked prospectively at attempting to induce occlusal overload and implant failure in an animal population. Now, 6 of those studies are in primates, very, very nicely designed studies. 1 was done in dogs, but to have 6 studies on the same topic in primates, which are enormously expensive, and the animal rights activity makes it more and more difficult all the time to do animal studies. But the outcome of those 7 studies have concluded that it's not possible to place an implant into hyperocclusion and knock it out of the bone. The evidence shows, for those who've done histology on these studies, they've shown that the bone density adjacent to overloaded implants actually increases rather than decreases, which is a demonstration of Wolff's law of bone physiology. And so the animal studies are very, very clear that occlusal overload does not have a direct cause and effect relationship with implant loss. And up until about 19 till about 2014, 2015, there was no other literature to look at relative to occlusion. But then in 2014, in the International Journal of Oral and Maxillofacial Implants, a paper was published. A very large population of patients looked at retrospectively. And basically, if you see a retrospective study, what that means is somebody decided to do a chart review on a slow weekend. Okay?
Right.
And so these two large studies were both chart reviews, historical retrospective studies of the causes of implant failure. And they very clearly separated early failure, which runs at about 55 to 60% of all implant failures tend to be early failures. And late failures, which the early failures being failure to integrate, the late failures are loss of osseointegration for some reason. And these studies both attempted to categorize the mode of failure for the late failing dental implants. And the first study showed, including fractured implants, the failure of implants caused by occlusal overload was about 70% of all late failures were related to fractured implants, overload, that sort of thing. And they defined occlusal overload as something that was seen radiographically or due to prosthesis loosening, screw loosening, or material breakage. I guess the question I would like to ask those authors is, how do you diagnose occlusal overload from a radiograph?
Yeah.
You can't do it.
And just because there were technical complications with these prosthetics, the conclusion was made that that was occlusal overload related failure because they saw screw loosening, they saw fractures.
Yeah, they didn't consider that misfit might have been part of the problem in that regard either. But the problem is now you have two studies that have said the predominant cause of late implant failure is occlusal overload. Although no animal studies have been able to replicate that. The danger of that is if Mrs. Jones comes to you, the restorative dentist, and you refer her to your surgical colleague for implant placement, the implant is placed, everybody's fine. She comes back to you and has that implant restored. And then 9 months later, she feels tenderness and maybe a little mobility in that implant, and she goes back to the surgeon rather than coming to you, the restorative dentist. And I can tell you from experience that the knee-jerk reaction when she says, what caused the failure, he will say that it was probably the occlusion was just high on the crown, which makes you the responsible party rather than him, even though at 8 months that was just a slow early failure.
Yes.
It had never
integrated in the first place.
So that puts the restoring dentist at risk for being culpable for late failures due to something defined as occlusal overload, which again, if you look at the true science on that topic in these animal studies, no one has been able to demonstrate.
Wow.
So there's no cause and effect relationship, but now the litigation potential is huge.
Goodness. So why is it that, I mean, this is not being talked about as much on the podium? Because we don't hear, we go to lots of meetings and we don't really hear this talked about. We do hear about other potential causes of failure. We hear about, is this a acceptance versus rejection with Albrechtsen, or we hear about, periodontal, disease as being a risk factor. But why are we not debunking this as much as maybe we should? What is happening with that?
Well, I've tried. But people, you heard it on the podium this morning, potential causes for failure. The first one that was mentioned, I won't mention by who, was occlusal overload. And my answer to that is, really? Where is your evidence?
Right.
Does it exist in any way, shape, or form other than these authors of these retrospective studies deciding that occlusal overload was the primary cause of late implant failure? It does not equate if you're really trying to discern the evidence.
Yeah.
Doesn't.
Implants wouldn't work.
Exactly.
And
Yeah. Seems like one of the greatest pieces of evidence for that not being an issue.
Yeah. The evidence is very clear that with today's modern, moderately rough implant surfaces, the short implant, if you can get it to integrate initially because the one advantage of a long implant is primary stability.
Yes.
It's harder to get a short implant stable at the time of placement, but if you can get it stable and integrate it, a 5 millimeter implant to replace a maxillary first molar is as successful and as effective as a 10 or 12 millimeter long implant. There's no difference with today's modern surfaces in implants that have integrated in their ability to successfully
So
carry
you're
load.
saying that crown to root ratio,
Crown to implant ratio.
right, does
Yeah.
not apply.
Crown to implant ratio is exactly the opposite of what you'd expect.
Yes.
Right.
The taller the crown to implant ratio, in other words, the more mechanically unfavorable it appears, the denser the bone is around
Right.
the implants. That's been shown in
It's a
several.
positive biologic response.
Right, exactly.
So what do you think? Do you? Our theory that we kind of kicked around the other day as we were discussing this article was, is this all coming from Mish and contemporary implant dentistry from back in the day? And rest in peace, great guy, amazing educator. But biomechanics was pushed forward as an idea of we need 2 implants for every molar, for instance, early on.
Right. We need to basically create non-shearing forces. Thread
Right.
design matters
Are we
beyond
still
Non-axial loading.
Right.
Are
Yeah,
we still
exactly.
living in the 90s?
Yes,
with-
we are. And I mean, and please, and you probably will want to cut this out of your dialogue, but I can't not say it. Carl was a good friend of mine, and we went back a long, long way. But when I ask at a program who here has Dr. Mish's textbook, several people, particularly our residents, will raise their hand, and then I start showing some of the statements out of that book versus what the true scientific evidence appears to be. And the term that I actually coined was that it seems that you're full of misinformation. And
Yes.
I don't say that with any disrespect
No,
at all.
no.
No,
Because
we understand that.
Because empirically, right, it would seem to make sense that surface area would matter, that length of the implants would matter. And I understand why that, from an empirical standpoint, we're thinking is like teeth. But as we've just talked about, short implants have been so successful. We have so much in front of us.
But not only are you thinking it like teeth, you're applying mechanical. Like his book mantra was so mechanical driven, like it applied even industry mechanics
Right.
to
Exactly.
biology.
Exactly.
And biology plays differently with dental implants. It plays differently with what you would think would work even in construction. Like if we pounded on a house on one
Right.
corner, for sure the foundation on that
So-
side's going to weaken.
So what does that
Right.
mean as we've kind of, I think, established that the implant occlusion as far as overload, that the data is not there in this discussion, but what is that, how does it change? You mentioned this being still expert opinion. If you're doing a full arch reconstruction on implants, so let's talk about how do you design an occlusion? Do you look at group function versus canine guidance differently? Do you, what are we thinking? Do we even have a basis of making those decisions?
Great question.
Yeah, the answer to that is there is no, again, evidence,
Yeah.
but common sense will tell you or will ask you of bilateral balance or group function or anterior guidance, canine protected occlusion, which one is easier to create? Canine guidance is easier to create. If you have, for example, a full arch zirconia prosthesis opposing another full arch zirconia prosthesis, and some will advocate you need to have, rarely do they say bilateral balance, but you need to have group function to distribute the load. Well, that prosthesis is so rigid, a 1-point contact is going to distribute the load throughout the arch just as well as 4 points of contact. So, to me, I would argue that you cannot create group function on an articulator without the advantage of periodontal ligaments of natural teeth to help you fudge it a little
Yes.
bit. If you've got ankylosis opposing ankylosis, the only way you're going to get simultaneous contacts is with very painstaking, judicious adjustment intraorally at the time of delivery. It's the only way you're going to get it. And most dentists are not going to be willing to do that. Simply, you can't afford to. And so if there's no evidence that canine guidance is in any way a negative plan, why not just go with canine guidance on all of these opposing implant restorations?
I like it.
Because it's easy to create, and we all understand what it means, so the technician has an easy path.
You can do it on an articulator in a lab.
Yes.
And you can put it in the mouth with confidence. Very quickly you can tell whether you've got it or not. With group function or, heaven forbid, bilateral balance, it's a totally different ball of wax.
You know, back to occlusion, one of the things that I used to do in my early practice was if I had restored an implant, and I started restoring so many that I began to, because of my training, I began to put articulating paper forceps on every hygiene cassette, because there's always that person that was going to walk in that day, and we never know when, that had the dental implant, and it was just so many patients that had dental implants, and I started checking occlusion on that. And then I challenged myself, and I said, how many people in the world are checking their occlusion? Because we know occlusion changes. We just listened to Dr. Cooper talk about 5 microns a year if that patient has erosion. And how often do we lose?
Right.
Canine
so we adjust
guidance.
that occlusion to keep it light, but then in next month, it's right back to where it was.
Well, I would argue that it's within an hour. If you have an implant opposing natural teeth, anything you attempt to attain in delivering that implant crown, the opposing tooth is going to shift within the hour and absolutely ruin your work.
Because it's an orthodontic device.
Exactly. It's an but it's also postural.
Right.
It's tissue saturation, fluidity. There are all sorts of reasons teeth move in their socket and orthodontically all the time. The biggest problem you have is when you oppose a single tooth implant against a single tooth implant, because they are not going to move, but all of the rest of the teeth are going to continuously move. Sometimes they're going to be heavier, sometimes only the implants are going to be super heavy.
That's why we see so many open contact issues and other things.
Well, the open contact issue is what we call mesial shift, which is a naturally occurring physiologic occurrence that maintains proximal contacts. As your teeth wear occlusally, they also wear proximally. And so the body the physiology has kept the teeth leaning forward to maintain proximal contacts. And if you have an ankylosed implant, all of a sudden,
that is not moving.
That's why that contact opens.
Well, we have to take
I love this discussion,
because
by the way.
this is where like you said, this is not new information. This has been out there for a long time, and yet surgeons all over the place are blaming failures, late failures or early failures, on this exact issue. And I just feel that if there was one thing I could change seriously about my relation, I have certain surgeons, that you kind of decide, hey, I'm going to work with somebody that does understand the literature, but not everybody has that luxury. So how do you approach a surgical colleague with that? What would you tell them is the most likely cause of these failures, early and late? How would you approach that?
Well, early failures to osseointegrate are usually something to do with, I hate to use the term bone quality, but I would say osteotomy quality, in that the bone might have been just slightly overheated at the time of placement. Dull drills tend to generate more heat, and some of the new guided surgeries, it's very difficult to get irrigation under that surgical guide. And so the tendency is to heat up a lot more bone than we used to do when we were freehand placing everything very judiciously with very, very slow RPM. RPM have gone way up in site placement now. And so are we ignoring the lessons that we were originally taught back in the early 1980s from the researchers in Sweden about avoiding bone overheating? Or another possibility with today's modern thread profiles.
I know where we're going.
Is over tightening. is
too much torque.
Too much torque. Yeah. I can show you implants that literally cracked at the time of insertion. We didn't realize it. We restored them. And this at 1 year follow-up, you've got 50% bone loss. You take the implant out, and there's a crack right down the side. But it was, and it's not an internal tapered implant, so the only way it could have cracked would have been when it was being torqued in. We didn't notice it at the time of placement, and it takes time to show up. But if I'm the surgeon, I'm going to blame the restoring dentist. I'm not going
Yes.
to blame myself for over-tightening it.
And I think that is where we're coming kind of full circle now to the next area where there is tremendous controversy, which is, well, the companies don't see it as controversy. They're all moving that way.
Yeah.
They're all moving it that way. And yet you have a few voices sort of crying in the wilderness, saying, Mike Norton, for instance, showing very low insertional torque values, very good ISQ values, and we're going on to having great success. And so the question is how, he asks is how much tight is tight right? And, it sounds like you feel that that's a concern.
Absolutely, it's a concern. The causes of early implant failure, I think, are fairly well understood. It's heat, or it's necrotic pressure on bone, or it's contamination. The problems come in with late implant failure. Why do these things fail late? Going back to that study that I said 70% appeared to be what I would call mechanical problems, overload or implant fracture. The other 30% were broken down into host response, inflammation, something else, and then peri-implantitis. How do you differentiate inflammation from peri-implantitis?
Right.
I mean, it's
what does that
ridiculous.
even mean?
Yeah. It's we're doing things very artificially, and I think you have to step back and look at what nature's giving you. Nature is giving you the very, very lucky outcome of osseointegration, and as long as you respect it and try to use the protocols for initiation of osseointegration, I think once osseointegration has occurred, that interface is the strongest point in the pillar of an implant-supported restoration.
Do you think we'll kind of end with this, do you think as we're looking into the future with the change in design, because I really want to just make sure that our listeners understand, do you, just from a pure expert opinion, theoretical idea, think we'll see an increase in early failures as a result of the way that implant designs are changing? Do you think it's enough significant change that we're going to see that problem? Because so far it doesn't look like we're seeing that borne out, at least early, but so many companies are now changing. Do you feel like that's going to be an issue?
No, I really think that the frequency of early implant failure, if anything, is dropping a little bit.
Yeah.
And I think the frequency of late implant failure is pretty much flat line where it has been over the years. I don't think the implant surface makes a difference. I think if the implant is torqued in properly, I don't think the thread profile configuration makes any difference in success.
Let me ask you this. How much torque is too much?
Depends on the bone you're putting it into.
That's a great answer.
Yeah.
But can we set limits?
You can arbitrarily set limits, yes.
Right.
35 Newton centimeters.
Right.
20 Newton centimeters. Where do you agree to proceed with immediate loading?
Do you think that's what's being taught, though?
I'm sure it's being taught, but it's what's being taught in Institution A is different than what's being taught in Institution B.
And the companies certainly are not talking about it that way. They're saying, hey, doesn't that feel good when it torques in at 75?
Yeah.
And if you break an inserter, well, that just means you got really good torque.
Right.
Well, the goal it seems to be like with these early things, in this first year of healing, and really now we have implants that are FDA approved to load and finish in 2 weeks. Because that's where crowns, we're finishing our crowns. You prep a tooth today, in 2 weeks you get your final crown.
Right.
Are we moving too fast?
Well, the whole issue of rapid solutions, teeth in a week or teeth in an hour or teeth in a whatever the day is.
Yeah.
Those things are all dentist-driven.
Yeah.
They're not patient-driven.
For sure.
It's exactly the same situation we have with ceramic implants, all ceramic implants. Your dentist says, well, my patients don't want any metal in their mouth.
Yeah.
And my question is, why don't they want any metal in their mouth? It's because you told them they didn't want any metal in their mouth.
Exactly. I'm glad you said that.
So good.
Interesting. Because, we look at these things. They're a problem looking for a solution,
Exactly.
And it's you almost have to do mental gymnastics to try to explain why these products are coming out to where you can fit them into a patient.
Right.
And I think we're definitely adapting. And this is something that Dr. Cooper spoke to a little bit as well, that we are so device-driven. We're so, material-driven that often we're forgetting about what our outcome really, what would you do if it was your wife, if it was your best friend?
Exactly.
And that's maybe not the way our products are being developed.
Which brings to my point. What time does our next lecture start?
We got about
1:30.
Yeah, we got what
30 minutes.
30
Oh,
minutes.
okay.
Yeah,
Because in that lecture, it's about what dentists prefer for their own molar restorations. And I'll bet the findings are that it's the predominant restoration they prefer is still yellow gold.
Interesting.
Yeah.
Interesting.
As he shows that.
Right,
Well, I think that this, if I know that our listeners are loving this, because what it's doing is it's challenging the way that you're thinking. It's challenging maybe you were coming into this discussion thinking occlusion was everything.
Well, it's a true challenge because, the mind thinks that if I overload something that it's going to fail.
Overload has a bad connotation.
It does.
Yeah,
it does. And you have to get beyond, like when we teach dental implants, we always say it's about marrying mechanics with biology.
Exactly.
And trying to do that
Right.
with a logical mind.
Yep.
It just doesn't work sometimes.
Yeah.
And I tell you what, you have to respect literature, but you also have to look at literature like you do and say, is this really a good study?
Yeah, was the study design good?
Right.
Because, when I look back, you mentioned, that I remember just because we were talking about this the other day, the Isidore study, which I think is the one that they were really trying to show, that overload could create a problem. But the amount of occlusal overload was crazy.
Since you brought it up,
Yeah.
the Isidore study was the only study where they were able to knock an implant out of a monkey's jaw.
Right.
But that wasn't because of occlusal overload. That was because the occlusal plane was a ramp.
Okay.
It was like a cam surface. So these were standard diameter implants, under 4 millimeter diameter implants. I won't even tell you the brand name. But every time those animals bit in hyperocclusion, they were literally bending the body of those implants.
Wow.
So the cause of bone loss was not the overload. The cause of bone loss was the movement of the implant itself.
giant
Maybe that's
lever.
why the
Yeah.
FDA tests all componentry at that angle.
At 30 degrees.
At 30
exactly.
degrees.
Yeah.
Well, thank you. So we'll respect
has
your
been a
time.
pleasure.
Thank you so much for being with us today, having this discussion. I think it's an extremely important discussion. I think it is everyday dentistry for
It is everyday dentistry.
every single person out here. If you understand what matters and what does not matter.
It's so good, man.
Yeah.
So listen, if you're listening to this right now and you want to hear more about this, you need to just like and subscribe. You
Absolutely.
know, the Dental Guys can be found on Apple Podcasts, Spotify, any podcatcher like that. Next month, we're going to be live streaming from the Academy of Osseointegration meeting.
Yep.
We've been looking forward to that.
Yes.
They have partnered with us over this next year or so
Yep.
to bring in some high-level people so that you guys can hear about it. But here's someone that's been published,
Right.
that knows the literature,
Yeah.
and that's what we're about, is about next level.
That's right.
Taking your knowledge to the next level, and so I'm excited about this. So stay tuned here as we're live from the American Academy of Fixed Prosthodontics meeting. It's been good so far. I'm Wes, the dental guy, for John and for Dr. Tom Taylor. Thank you for joining.